All right, I'll go ahead and get started. So I'm Emily Ryan. I'm a first-year trauma fellow at Ryder Trauma Center, Jackson Memorial Hospital out of Miami, Florida. I'm going to be presenting a case of blunt hepatic injury. So I'm just going to give the case presentation and then review sort of intraoperative decision-making and techniques to control liver bleeding, and also discuss the risk, benefits, and outcomes following IR intervention for blunt hepatic trauma. So the patient was a 63-year-old male unknown who presented to our trauma center via EMS after he was on a scooter that was struck by a car. He came in with a GCS of 15 and he was complaining of lower back pain. His airway was patent. He had bilateral breath sounds, was satting 99% on room air. His heart rate was normal, his blood pressure was normal, and he had palpable peripheral pulses. He had a base excess of -3 and his hematocrit was 35. His pupils were 2 millimeters reactive, and again, GCS 15, he was moving all of his extremities. He had some scattered abrasions, but no deformities to his extremities. And on secondary survey, he had no peritonitis, and his TEG and PFA were within normal limits. His chest X-ray and pelvic X-ray were normal. However, he did have a positive FAST in the right upper and left upper quadrants. Now, after several minutes during his initial resus course, he did develop hypotension. His heart rate remained normal, and he remained mentating normally with, on exam, bounding peripheral pulses. So I wanted to just stop there and see what you thought the next step should be. If anyone wants to jump.
Yeah, please, if you have one comment, raise your hand, otherwise we're going to start calling some people. Dr. Frisby, how are you, sir? So what do you do with this patient right now? Dr. Frisby? I thought he was there.
That's okay.
Dr. On track.
Yes, good afternoon. So his blood pressure decreased, so at this point he needs several IVs, and I would start giving him blood. If he responds to the transfusion with a normal blood pressure that remains stable, at that point he can go to CT scan to see the source of the bleeding. If, based on the title of your presentation, if it's the liver, depending on what you find, it might be something that can be controlled without a laparotomy at interventional radiology. If he does not respond to an initial transfusion, or if he's a transient responder, based on the ultrasound, he really needs to go to the operating room for a laparotomy.
Okay, thank you. What about Dr. Cassin? Dr. Cassin, anything else?
Good morning. Can you hear me?
Good morning. Yes.
Thank you, sir. So, a blunt trauma in a 60-plus-year-old man, and he appears normal when he comes in, and suddenly he becomes hypotensive. The common organ that is injured in blunt trauma of the abdomen is the liver. So I would put my 2 bits on the liver being the culprit here. So I would say that he's bleeding from his liver, and I would resuscitate him with whole blood. I don't know whether you have whole blood in Miami Trauma Center or not. You must have that, because they have that at OHSU here in Portland, Oregon.
Yeah.
So I would resuscitate him adequately, and if he responds, if his blood pressure comes up and heart rate goes down, and then he will become a candidate for going contrast enhanced CT of the abdomen, perhaps pelvis as well.
Yeah.
Thank you.
Okay. I would like to see if Beth Stubbins is around. So usually she's in Africa. So Beth, how are you? Can you hear us?
Hi,
Yeah.
yes, I can hear
Hey.
you, and I am in Africa.
Yeah.
We
So
don't have
tell me, what did
anything
you do
like
there?
CT or anything. So, I am at a big mission hospital called Nkoma Hospital, which is an hour outside of the capital city of Lilongwe. We have no CT, we have intermittent X-ray, and most of my imaging is done with my butterfly ultrasound on my phone.
Wow.
So my options are a bit different than the rest of you. But I agree with the other two commentators here about this case. Obviously, he's demonstrating that he's in shock and needs 2 large bore IVs and starting at probably a mass transfusion protocol or at least a couple of units and see how he does. There's not concern for a neurologic, injury as a cause of his hypotension, even though he's not tachycardic. We've been fooled by, people who don't follow the rules plenty of times. So I agree with everybody before me.
Amazing. Keep in touch. Stay on, because we're gonna need your opinion on this case. Okay, it'll be nice to see how it manages with not a lot of research. Okay, Emily, please
All right.
keep going.
Okay, so we did what you all said. We started by transfusing him. Interestingly, we were a little bit suspicious because he did have bounding peripheral pulses. So as we transfused him, we placed an arterial line, and his invasive pressure actually measured higher. After the unit of PRBCs, he remained stable, and we were able to proceed to the CT scanner with that. So this is his scan. You can see he's got a severe liver injury with several points of contrast extravasation, mainly in segment 6 and 7. He's also got blood or fluid near the spleen. And those were the main findings. So, this was read, and I guess we discussed with radiology, but this was read as a grade 4 hepatic laceration with active extravasation. And then there was a question of possible retrohepatic caval involvement. There was a low-grade splenic laceration, and then he also had some other findings: orbital fracture, some rib fractures, and a sternal fracture with small retrosternal mediastinal hematoma. So we gave him an injury severity score of 35. So after the scanner, the patient remained hemodynamically stable. However, shortly afterwards, developed increasing abdominal pain and tenderness. So at this point, what would the next step be for you all?
Okay, let's see. Dr. Felipe Vega, are you here? Are you connected, Dr. Vega? From Mexico? Maybe not. Let's go, Dr.
Antonio,
Ben.
here.
Yeah, hey Felipe. Hey Felipe.
How are you?
What? Good, and you?
Yeah. Well, the next step for us right now, I think, is to go to the interventional radiology, see what happened with the liver, and also with the spleen. If you are already there, you can make a shot and see what happens.
Okay.
Okay. Dr. Frisbee, what did you do in this patient?
Is he holding on to his pressure?
Yep, he's still hemodynamically stable, but he's developing increasing tenderness and peritoneal signs.
Well, you're either going to have to put him through a CT scanner, which is probably problematic at this time, or you're going to have to open that abdomen. And I think I probably would open it. And, once you get where you can see the liver, suck out all that blood and you can see the liver, I would, since you're on the massive transfusion protocol, take your hands, one on either side, and squeeze it together and see if it'll stop.
Mm-hmm.
That's just a temporizing measure, but if it won't, it'll give you an idea of a caval injury at least.
Mhm.
But that's the only suggestion I have at this point.
Okay. So,
Okay.
oh yeah,
Yeah,
go ahead.
doctor, just Bet, you don't have interventional radiology there, so what do you do with this patient, Bet?
Now, this patient would have never made it to the hospital over here.
Oh, wow.
But I think for this case, you know, the CT shows that the injury is in a very, very difficult place to access operatively. And generally, if there is like a retrohepatic cable involvement, your best bet is to pack it, you know, and not try to operatively fix it. If you can get into interventional radiology, ideally, if you have a dual room in that context where you can kind of open him if he's getting a compartment, or if they can't get control, you know, with IR. But I think he may end up needing both operative and interventional access. I don't know, but it's not a fun place to operate. So, I mean, in this context for liver injuries, basically all we can do is open and pack and stuff some momentum, which is a lot smaller over here than in the American
Right.
population.
Yeah.
And we don't even have like IOBAN or anything for open abdomens, so we've done sort of a Bogota bag sometimes, or just closing skin and then coming back in a couple days for you know, more definitive laparotomy.
Right.
Okay. Back to you, Emily.
Okay. So it sounds like people were sort of leaning towards IR first, but maybe OR. So we took him to the OR for peritonitis. And what we encountered was about 1.5 liters of hemoperitoneum. And he actually became hypotensive on induction. So MTP was initiated. We evacuated the hematoma and packed all 4 quadrants. And then once, you know, we had, you know, adequate lines and anesthesia had, you know, caught up, we sequentially removed his packs. And we actually weren't able to identify any injury to the surface of the liver that we could see, no lacerations. And we, you know, explored the retroperitoneum. We could not identify any caval injury. There was no RP hematoma. So, you know, in this situation, we were a little bit frustrated, but we repacked the liver and left it. And then turned our attention to the spleen, which had ongoing bleeding from the hilum. So we performed a splenectomy at that point. So at this point, we repacked the liver and okay, so you guys have already said basically that you would also want IR involved, which is what we did. We don't have we do have a hybrid room. We have a IR compatible table, but they still have to bring the C-arm in. So they came in and performed a diagnostic angiogram, which actually showed no active arterial extravasation. However, given, you know, the findings on his CT, they were able to perform empiric gel foam embolization of the right posterior division of the hepatic artery. Once this was done, we performed a temporary skin closure of the upper portion of the midline wound to help compress the liver and put a negative pressure Abthera dressing on it. And his transfusion requirements, he really received 2 whole blood, 2 PRBCs, 4 of FFP, and 1 of platelet. Unfortunately, I don't have the images from the embolization, but this is just kind of a schematic showing, you know, again, they didn't identify any active extravasation, but empirically embolized this posterior branch of the right hepatic artery. So his immediate post-op course, he actually didn't receive any more transfusions after the OR. His hemodynamics improved, and he was taken back 24 hours later, and the packs were removed. His liver was hemostatic, and drains were left in the splenic fossa. So, unfortunately, his ICU course, he developed multiple complications, and I'll discuss those briefly. But this right here on day 0, this is his initial CT scan. You can see kind of the extent of the liver injury. And then day 4, we got a repeat CT angio to kind of evaluate for further bleeding. He hadn't been hypotensive, but as part of our protocol, this was to look for any signs of rebleeding. And what we see is not bleeding, but some more areas of liver necrosis here, kind of in around segment 5. And then, further out, you can see that these areas of necrosis have kind of evolved. So unfortunately, he developed multi-system organ failure. He developed severe ARDS requiring proning, prolonged intubation, and eventual tracheostomy. Despite being started on DVT prophylaxis, he developed a PE and ended up requiring an IVC filter. From that splenectomy, he did develop also a pancreatic leak, which required an additional IR drainage procedure. And then most significantly, he did develop those areas of hepatic necrosis and ultimately went into liver failure. We didn't know at the time, but he did have underlying alcohol use disorder. His liver didn't appear cirrhotic in the OR, but we thought this might be a contributing factor. And he, his ICU course is still ongoing, and he's been in the ICU for 2 months. This is just his kind of bilirubin trend. So really what I wanted to focus on with this case was kind of the initial management of blunt hepatic liver injury.
Yeah, Emily, let's ask around the room about what did they think about the case, or they may do different. The comment.
Yeah,
So,
sure.
Dr. Cassim,
Emily, I think you did very well initially.
Mm-hmm.
And I think I would not have done the gel foam embolization empirically. I think I don't like doing anything empirically unless I know what I'm doing.
Right.
And then, of course, cirrhosis of patients who are alcoholic, even though you can't see evidence of cirrhosis by naked eye, underlying liver tissue may be cirrhotic, and you may not be able to appreciate it in the drama of the whole case,
right,
in the OR. And one of the factor in liver necrosis following injury is, number one, is cirrhosis.
right.
And I think your surgical management has been really, really good. Except the patient has underlying problems, and the devil is in him. The cirrhosis is contributing to his prolonged hospital course and ill health. Maybe even it might take his life. I like the way you managed it.
Okay. Thank you, Dr. Cassim. Dr. On track.
Yes, very, very strange. I was a sort of a elderly man in his 60s, and even if he has alcohol use disorder, does he have a history of liver disease? Does he have varices? Has he shown signs? Yeah, so really a normal liver initially, and he was really only hypotensive after induction in the operating room. So that was brief, it was witnessed, it was reversed right away. So, and then to go into multi-system organ failure, it's just very bizarre. Those lucent areas in the liver, they look more like contusions, that you can see after with blunt liver injury that just evolved, say necrosis, but it's really from the blunt trauma. And he's got enough liver there that he should recover. So it's all very, very bizarre that he should have this course. About the embolization, you're just embolizing an area of the liver that was destroyed. So I think that's reasonable, and and there's no evidence that he had a shower of emboli elsewhere in the liver based on the CT scan, the last CT that you showed. So it's all very, the ARDS, everything, very, very strange. And I don't know if it's related to any medicines he's taking that you didn't know about or you still don't know about. But at this point, he needs very good ICU treatment for multi-system organ failure. But at age 64, and if he's a smoker or a drinker and a lot of underlying risk factors, the mortality is high. But I think really the only thing to do here is very, very good intensive care treatment for the multi-system organ failure. And if he pulls through, I expect the liver is just going to recover, and you should be able to pull him through. So, but unusual, very strange occurrence, though.
Yeah.
Thank you, Dr. Steubenbett. Tell me, what do you think about what would you be able to do at your hospital?
None of this.
None of this.
No, there's no interventional radiology in the entire country of Malawi. And even the concept of damage control surgery has been introduced by me in the last 2 years. So, yeah, I find these presentations very nostalgic to where when I had resources. No, I think the treatment was really good. I think it's hard to say what would have happened to that segment of liver if it hadn't had the gel foam. It was already pretty devascularized, it looked like on the initial CT. I did have a patient back when I worked in the States that had a huge gunshot injury, like a high-powered rifle through most of the liver and had almost the entire liver gel foamed. And he ended up with massive hepatic necrosis and was, similar, sort of in the ICU for months and all of that kind of thing. So I think gel foam can sometimes have those effects, but I think in this case, the liver was already pretty devascularized, and so there's no way of knowing if the gel foam had any effect on that or not. He sounds like his liver was already a bit damaged from his lifestyle. So I think you guys did a great job, and hopefully he pulls through.
Okay, thank you. Dr. Felipe Vega in Mexico, any additional comment? How would you manage this patient at your hospital, please?
Yes, I'm agree with Dr. Kasim that maybe the empirical from the utilization was not indicated totally. But I don't know if in the past years when we opened all the hepatic injuries, we also pack and repack, and also with this patient we have a lot of liver failures because of damage of the segments of the tissue. I don't know if they packed the first time, they saw some contusions in the liver that may worse the outcome.
Okay, thank you. I see here Dr. Roberto Calderon Zapata from Peru. Dr. Calderon, what could you do at your hospital in Peru?
Good morning. So we have more limitations. For example, our blood bank has limitation. We cannot do a real massive transfusion protocol as a level 1 trauma center because blood bank counts each pack of blood we give to the patients. And we don't have interventional radiology at this time. We have one interventional radiology, but he doesn't have the equipment to do angioembolization. So he only can help us out with interventional radiology drainage, image guided. So with this kind of patient that has I see the initial CT scan that looks like a high-grade liver trauma. Well, if the patient remains hemodynamically stable, we just keep them under observation in the ICU with serial abdominal examinations, with trending hemoglobins, with hemodynamic monitoring. But if there is a just any decompensation, we have low threshold to take the patient to the operating room. If the patient, well, is unstable, we obviously take the patient to the operating room with a low threshold for decompensation, just to do what you said, just to open up the belly, check the injuries, try to stop the bleeding. In the case of the liver, just do the initial bimanual compression to with a packing, and if it works, we just keep the packings in and come back later the next day or a couple of days. Otherwise, if the liver keeps bleeding, we just keep going with the exploration as the training says, as the outcome states. Let's do the Pringle maneuver, the suture ligature of the bleeding sites, and if it doesn't work, do the hepatic vascular isolation. That, well, it seldom happens. Actually, I haven't done any case with hepatic vascular isolation. So we also, in summary, we usually take these patients to the operating room.
Okay.
Well, I have to mention also that I agree with the colleagues that empirical embolization, it was not a good idea, really. Even in a healthy liver, necrosis is expected with the possible outcome. We can have this sepsis, liver abscess, and so on. Okay, that's what I have by now. Thank you.
Thank you. You have a question for Dr. Shirokobe. Dr. Shirokobe, you can make your question and comments, please. Dr. Kobe?
Hello.
Hello.
So I wrote down the chat in the meeting chat. So did you discuss about interventional radiology between trauma surgeon and interventional radiology guides before performing interventional radiology? If so, was there any concern about liver necrosis before performing interventional radiology?
I mean, I think that just the degree of injury and the fact that, you know, he became peritonitic, we had to take him to the OR, and the amount of hemoperitoneum we encountered, I think we were just concerned for ongoing bleeding that we couldn't access surgically. And so I think, again, in retrospect, thinking about, how his course went, could we have maybe waited and gotten a repeat CTA in 24 hours, or even just had IR come back and perform a second look angiography, that could have been a better option for him. But, I think we were just concerned for ongoing bleeding, and maybe we weren't able to see it on the angio. So the empiric. Yeah.
I'll jump in there also, Emily, if you don't mind. This was my case operating with Emily. And yes, there was a intra-operative discussion with IR after we had packed the liver and found no external signs of injury to the liver. And so, presumably intrahepatic extravasation. And IR did their angiogram. They showed us the images and showed us the absence of extrav on their intraoperative images, and we were comparing that to the pre-op CT. And there was a pretty heated debate, basically between myself and IR about whether the extrav seen on the pre-op CT was from the portal system, branches of the portal system, intrahepatic, and that was the way I was leaning. And if that were the case, then I wanted to be careful not to empirically embolize, because presumably there would be, disruption of portal perfusion to that portion of the liver. And when we would embolize the hepatic arterial embolization, we would definitely get lots of necrosis. But the interventional radiologist really came down hard on the interpretation that there was actually hepatic arterial extravasation on the pre-op scan. And honestly, looking back at the phasing, I think the phasing was such that it's almost impossible to know for sure. And so their interpretation of the absence of extravasation intra-op was that we had packed effectively and we couldn't see the bleeding at that time, but it could start again if once we unpacked. And they ultimately convinced me, and is I guess sort of what was in my mind in asking them eventually to go ahead with empiric embolization is I didn't have clear metrics for when it would be safe to unpack the liver. If we had extrav pre-op, we didn't do anything with IR, and all we did was pack, then it was going to be unclear to me when you could safely return to the OR and unpack and expect the intrahepatic bleeding to stop. So, given the patient's course and subsequently finding out that he's an alcoholic and how much it's cost him to lose so much hepatic function, if I could go back, I would probably stick to my guns and ask them not to empirically embolize and keep him packed for a couple of days and follow him. And if he ends up requiring a subsequent angiogram and embolization, then fine. But that was the course of the discussion.
Perfect. So Emily, go around, please. Go keep going, please.
Sure. Yeah. So bear with me because I know there are a lot of senior trauma surgeons here, but I kind of just wanted to go over some basics about liver injury and management, and then we'll get into indications for IR and complications. So we know that about 15 to 20% of liver injuries require immediate operative management, and indications are hemodynamic instability, peritonitis, the presence of other intra-abdominal injuries that require OR, or as is the case for our colleague in Africa, an unsuitable level of care for close ICU monitoring. So this is a chart basically comparing the percentage of initial operative management in mild versus severe liver injuries. These are like 3 different grading systems, but we're now most often using the AAST 2018. And as you can see, the initial mortality is much higher in severe liver injuries, operative management, as is mortality. In hemodynamically stable patients, we know that non-operative management is safe, and recent studies show that between 90 to 100% success rate for non-operative management, with 90% being the lowest in grade 5 injuries. And this has been attributed to multiple factors: improved CT imaging, angioembolization, and improved techniques in resuscitation. Right. But the downside is that, with a decrease in the number of patients who go to the OR, there's a loss of experience in operative management. And one study found that the average total number of liver injury operations for graduating chief surgical residents was 1.2 cases. So it's important to understand basically the techniques for operative management of liver trauma. And this is just a kind of an overview of all the different techniques that we know and when they were developed. And the Pringle maneuver was developed over 100 years ago. And all of these techniques, the Schrock shunt in 1968, hepatic packing, and then really not until the early 1980s was damage control surgery kind of at least demonstrated in the literature to be beneficial and actually decrease mortality. So this schematic is from COSAR from 2011, and this is really kind of the definitive management algorithm. But basically, you kind of stratify liver bleeding into major and minor. It's important to get good exposure by extending your incision superiorly, evacuating the hemoperitoneum, and immediate liver packing. At this point, this is when, once everything's packed, you can proceed with your resuscitation and allow anesthesia to kind of catch up, correcting coagulopathy and preventing that lethal triad. And then here, some people say to mobilize the liver for better packing, but I know everyone does something slightly different. Oops. So at this point, if you're hemostatic from packing, we've found, or we know that damage control surgery actually improves mortality. So leaving the patient packed, temporary abdominal closure, and then taking them back to the OR once their coagulopathy is corrected, they're not hypothermic, and their physiology permits. So at this point, there's, and this is kind of where, this is critical to our discussion, but the idea of post-op angiography. One study found that 62% of patients after undergoing initial damage control laparotomy for liver injury, 62% were found to still have active extravasation. The question is, of these patients, how many of them would have stopped bleeding just from packing versus would require embolization? We know that there's a high complication rate after embolization. I'm going to talk more about that later, but up to 40% complications. So with bleeding is not controlled with packing, basically your next step is the Pringle maneuver, and that's to stop inflow to the liver. So here's just a nice picture of that, either using a vascular clamp or a Rommel tourniquet. And then once, if the Pringle maneuver controls your bleeding, then you can explore and further identify which vessels are bleeding. So this can be through a variety of techniques, but finger fracture is the one that's most often described. Then direct ligation of actively bleeding vessels and injured bile ducts. You can also perform deep parenchymal sutures using absorbable suture on a blunt tip needle. The data for performing, liver resection on the initial operation basically says don't do it unless the liver is kind of reduced to a pulp and you can kind of just scoop it out. But non-anatomic debridement of any devascularized or destroyed parenchyma, they say, is okay. And then omental packing is a good technique that can help kind of provide additional compression and fill dead space. So here on the left is the finger fracture technique, but basically you just push through the parenchyma. You can identify any bleeding vessels and suture ligate them. Here are the deep parenchymal sutures. And then this is an omental pack where basically you just take the greater omentum and leave the gastroepiploic as the arterial blood supply, and then pack it into the liver laceration. If the bleeding, if you can't control bleeding, arterial bleeding with just suture ligation, then there's selective hepatic artery ligation, which, if you think about it, is kind of like IR embolization, except not as selective. So this obviously carries a high risk of liver ischemia and necrosis. And then going back, if your Pringle maneuver doesn't control the bleeding, you have to assume that there's a juxtahepatic venous injury. So at this point, we know, and this is what somebody had mentioned earlier, but for these types of injuries, survival is better if they can be packed and are hemostatic than by exploring them and trying to repair these vessels, because again, the exposure is so difficult. If additional packing doesn't provide hemostasis after the Pringle and in the juxtahepatic space, then the technique of total hepatic isolation is described. And basically you have to get control of the subhepatic and suprahepatic vena cava. The atriocaval shunt is a technique that's been described, however, carries a very high mortality. Additionally, there's veno-venous bypass, which has been described in liver transplant. But these are, very rare things that can happen, and we don't see it very often. So here's the atriocaval shunt. Basically, it's a chest tube, that is introduced through the atrium, and you either have a balloon or you put a tie around the vena cava here and here, and that isolates the veins from the liver and basically allows you to keep filling the heart. And this is veno-venous bypass. And then the last portion is, when you take these patients back, and we always say, it's not 24 hours or 48 hours, it's whenever their physiology permits. And then regarding drain placement, if you suspect a bile leak, it's good to leave a drain, but routine drainage is not required. And then just a comment on minor bleeding. There's all of these hemostatic agents in addition to argon and electrocautery. In this study, basically, they found that this is actually an elective liver resections, but there was no difference in post-op transfusion requirements with the use of fibrin sealants or matrices. However, there was lower rates of bile leak with these two things. Something interesting. So then moving on lastly to the use of IR embolization and blunt liver injury. The indications, basically, the patient should be hemodynamically stable, because if they aren't, then usually they're going to the operating room. Patients who have a higher grade liver injury, and then if they have an arterial contrast blush or even a venous injury. So in patients with high-grade injury, angiography can confirm an arterial injury and lead to embolization in 50% of patients, and has a reported efficacy across multiple studies in the really between 80 and 100%, but the literature I was looking at said 93. 12 to 28% of patients who undergo initial immediate operative management did require a secondary embolization to control recurrent bleeding. So there's not great literature on complications following IR embolization. Most of them are smaller single institutional studies. There was a systematic review from 2016 that basically looked at over about 11 studies, and found that the rate of hepatic necrosis was about 15%. They didn't really say the degree of hepatic necrosis, and none of them really spoke about, liver failure, but it's not as high a rate as you would expect. The rate of abscess formation was about 7.5%. For some reason, they didn't record the pooled incidence rates here, but you can see the risk of gallbladder infarction was, not insignificant, as well as bile leak or biloma. Then lastly, this is a study from JACS in 2023. It's a multi-center study of perioperative hepatic embolization as an adjunct for management of major hepatic trauma. And this basically looked at patients who went to the OR initially for their liver injury, and then underwent perioperative. So they didn't always, basically it included both pre and post-op angioembolization, but the whole point was they were looking for complications in the embolization group. So there were a total of 442 patients enrolled, and 20% of them underwent perioperative embolization. Now, what's interesting is that in the group that underwent embolization, there were more complications. There was a higher rate of biloma, abscess, either of these two or pulmonary complications. And the embolization group required more ERCPs, more return to the OR for bleeding, drainage of biloma and abscess. The issue with this study, however, is that this was not a randomized controlled trial. This was a prospective observational study, and there was a large amount of selection bias. If you look at their table 1, the patients who got angioembolized had a higher injury severity score. They were more often to have blunt injury. They had higher double AST grade injuries. They were more likely to undergo damage control. They were more likely to get MTP. They had a longer length of stay and longer ICU stay. What's kind of miraculous about this is that the mortality rate, despite the angioembolized patients being sicker overall, the mortality rate was equal. It was 24 in both groups. So what I sort of take from this is that, first of all, we don't have good data looking at outcomes for angioembolization. But it seems that even in sicker patients, if their mortality was the same, then there must be some benefit. So in summary, 15% of blunt liver injuries require immediate operation. Non-op management should be the standard of care in stable patients. Up to 10% of patients fail non-op management. And then operative management should proceed in kind of a stepwise fashion, prioritizing packing and damage control with stepwise vascular isolation. And then IR angioembolization actually has a fairly high success rate. Patients who undergo embolization tend to be sicker. And the most common complications were liver necrosis, biloma, abscess, and gallbladder infarction. But we're sorely lacking in prospective high-quality data looking at outcomes among these patients. So that's it. I'm open to any questions you guys have. No?
What was the basis for an empiric angioembolization?
So I think Dr. Carter kind of mentioned that the issue is when you have a scan that shows ongoing or that shows active extravasation within the liver parenchyma, there's not a clear point when okay, this patient's safe to unpack. So I think that was, but again, he said, it was not, he wanted to hold off basically. And the interventional radiologists were kind of adamant. So it was kind of that shared decision-making. And yeah.
I mean, I still have to own it. At the end of the day, I was convinced by them that there had been arterial extrav that was intrahepatic and that we could intervene upon with a catheter in place. And I agreed to going forward with the gel foam. But yeah, I hope that answers your question, Dr. Proctor.
Okay, Dr. Ontrak has a question. Dr. Ontrak?
Yes, I don't know that you can blame the angioembolization for all the problems this patient had. And you were there, you saw it done. I guess that the embolization was specific to that segment of liver that was already destroyed. So, if that's the case, how do you can't really blame it for the other areas of contusion and necrosis, and and I don't see how that would cause multi-system organ failure. But if you were there and observed, was it actually specifically was the catheter embolizing specifically the vessel to the segment 7 that was devascularized and totally necrotic anyway?
Yes, you're being very gracious as always. But yes, we were there, and it was a side branch of sort of distal intrahepatic posterior right hepatic artery. And so our in the absence of extravasation seen on table, the best we could do is correlate with the CT scan that we were all looking at and try and get out to where the extrav had been seen on the CT scan, as you know. And I agree with you that it was, you know, embolizing in the area of a pretty heavily injured liver in the first place. So it's a lot of this is kind of unknowable, I think, but
I mean, you could see where the gel foam was going. You could see the vessel
right
with the
yeah
opacified. Yeah, I don't. The point is well taken, but I don't know that you can blame everything on that. I mean, it's just. I think it's a bit of a stretch. But anyway, if I were an interventional radiologist, I would look at that last study that Dr. Ryon showed and say, look, angioembolization save lives. That's the only conclusion. But the point is you have to choose the patients very carefully, though, and only do it to the ones that are really in bad shape, that are hypotensive, and that sort of thing. And anyway, how did the patient do? Is it too soon to tell? Is he still in the ICU?
Yeah.
Yeah,
exactly. He's still in liver failure. He's still, sick on the vent. I mean, he's trached now, but
But how is the ARDS improving?
Yeah,
And
ARDS is improved. He's still on dialysis. His I mean, those are his major hurdles, the liver, and yeah.
And the prothrombin time, and the liver enzymes.
The PT is elevated, but not. I think his INR was 2.
Yeah, it sounds like there's a good chance of pulling through, but it's a tough case. And Dr. Stubing presented what she would do in Malawi, that in Africa there are lots of these because so many people ride scooters and motorcycles, and they get thrown off. They land on their back. I had a case like that in Guinea. You see multiple rib fractures, posterior right lower ribs, and then the big disruption of the liver posteriorly, like you saw in this case. And the problem there is there's almost no blood available. There's no CT, and you can do ultrasound, but it's just there's not much you can do in those cases if there's no blood. One patient I had like that just died because of no blood to transfuse. But it's the big difference. At least here you have all the means to take care of these patients. But I think very interesting case.
Yeah, I can see here Dr. Lanin has his microphone on. So, Dr. Lanin, what do you want to say about this case, please, sir?
Oh, that must be a mistake. But I would say one thing: you have to be alive to have a complication. So sometimes someone's dying, you're out, you save them, but then they're going to go through all these problems. So, that's probably what your study showed also.
Right. Yeah, very true. Thank you, Dr. Lanin. So let's ask Dr. Vega. I can see Dr. Vega has a lot of people with him. Dr. Vega, can you do the summary of the case and all the teaching points of this case to the group, please? Dr. Felipe Vega from Mexico. Yeah.
Nice summary about the case and the references. I think it's a good case to know when to embolize some hepatic and not, and what the main complication we can have if we have a case like this. Congratulations.
Yeah, I think he missed you, Dr. Vega. Okay. All right, Dr. Carter, was your case? Any final comment, sir?
no, it's just standard curveball first year attending life.
You did great.
You did all right.
I still remember my first years attending here at as well. So stuff. So Emily, great presentation, great case. Thank you for preparing not only the case presentation, but a review of the planning, the strategies to deal with this kind of injury. Okay, thank you very much. Great job.
Thanks for all your input.
Yeah, you did a good job. Really
Yeah.
good job.
So see you all next week, Monday. We're gonna have another case. Thank you very much, and please, the ones that planning to go to Peru, please. And then our Congress is coming through, and we're gonna have a great conference in August in Peru. Thank you very much.
See you, Tony.
See you. Bye bye.